Thank you very much. I want to add my welcome to this conference. Thank you to the government of South Africa, to all the organizers for bringing us together. I could hardly have imagined this event happening a decade ago. I'm truly grateful for the opportunity to provide some remarks here at the beginning to frame the conference. I hope to stimulate some reflection and some critical thinking about the way forward through my remarks. When I started out as a pediatrician about 25 years ago, newborn health was really not on the agenda. The agenda was broadly focused on child health, rightly so at that time. There were 12 million under 5 deaths in 1990. But newborns were basically invisible to health practitioners at that time. I remember traveling in northern Bangladesh trying to understand this situation and going from health facility to health facility, looking for newborns and finding none, and was kind of stunned by this. I realized at that time that there was a huge gap in the child survival agenda, the newborn period, and that on the other hand, we had a huge opportunity to make a difference. And this really ignited my passions for this field that have driven me since then. But there was a prevailing point of view at that time that newborn care was difficult. It was thought to be highly technical, expensive, something that was really specialized, something that you did in newborn intensive care units with neonatologists, kind of out of reach. And as a result, many health practitioners were quite intimidated to venture into this field. And so child survival focused on the quote-unquote easy things to do at that time, things that we knew a little bit more about, understood better, knew what the interventions were, and so we began to implement them. And we made remarkable progress. But that left the newborn out of the equation. But now the time has come. It's time to do the easy thing, and that easy thing is newborn health. This conference, now for the first time, rightly focuses on this area that has been neglected for quite some time. Improvements in in maternal and child health have gone at a greater pace than newborn survival. We have made progress, but it's been stubborn and it's been slow. And to change this pace, I believe that we need to shift the way in which we're working. And when I was first asked to deliver this address, I found myself looking at the title of the session and kind of reflecting, well, what does this mean? What might this imply? The global commitment to reducing newborn deaths. I found myself asking, what and where is that commitment? Can we really say there's a global commitment? Do we see countries committed to newborn health, making that a priority? How about donors? Who are the donors who are prioritizing and funding newborn health? And who among civil society organizations and private companies come to mind when you think about deep commitment and expertise in newborn health? All of these lists are growing, which is really fantastic. We're seeing that here today. But all these lists are much shorter than they should be. And when we talk about a commitment to newborn health, is it a commitment to newborn health that we need? Or do we aspire to more? Is it something more that we need? I present this list of questions as a way to stimulate our thinking, because I think if we can answer these, I think we can accelerate our progress. The answers will lead to more effective action and to more lives saved going forward. Well, as we can see here at this conference, newborn health now has a place on the global stage for global health. We see it increasingly in reports on research, from programs. We're seeing it in the social media. We had a great Twitter chat, a series of tweets leading up to this conference in the 28 days before that. I don't know how many of you participated in that. A few of you. We need more of you. It's a lot of fun. Get involved. We've seen newborn health gain visibility as the global health community has looked at MDG 4 and realized that there's no way we're going to achieve that without accelerating our progress in newborn health. We've heard about the report that Save the Children will be coming out with around Mother's Day, calling attention to the first day, the day of childbirth. We have interventions. We have things that can be done. We're making progress. I think it's important that at this conference we pause and take some time to reflect on the progress that we've made and to really tell ourselves, good job. We're really making progress. About 15 years ago, and David mentioned this, an informal network of a few global public health professionals recognized the need for newborn health and started to call for more attention to it. Save the Children launched the Saving Newborn Lives initiative, supported by the Bill and Melinda Gates Foundation, and then brought in other partners, and together brought needed attention to this field. Collectively, we all were able to identify the causes of death. We were able to identify interventions to avert most of those deaths, and we're able to identify potential delivery pathways for those interventions. And this led to a critical revolution as we began to gain experience seeing this through research, through program implementation. We increasingly realized that things could be done, things that actually are pretty simple. And this exploded the myth that was prevailing that newborn care is difficult. We now know that's simply not true. A few years ago, this was a paradigm-shifting idea. No longer could we ignore the newborn period. Excuses were all gone. We now know of a number of simple interventions that can make a big difference. We've heard a little bit this morning already about kangaroo mother care. Let's talk about that a little bit. This is an intervention that can be provided at health facilities for preterm babies and extended to use in households. It's a very simple, natural act of a mother, sometimes of a father, of other family members, holding a baby close, skin to skin, stimulating breastfeeding, providing warmth, reducing infections, and reducing mortality by about half. Estimates that we have today suggest that if we could scale this up, just this intervention alone, we could save 1,500 lives around the world every day. Or take antenatal corticosteroids, another intervention discovered around the same time, back in the 1970s, widely used in high-income countries where coverage is about 90% in cases of threatened preterm labor. If we could scale that up in low and middle-income countries, we could save another 1,000 newborn lives around the world every single day. Despite these remarkable changes in our level of understanding, ways of averting newborn deaths, newborns continue to die, and the proportion of under 5 deaths in this period, as we've heard already, continues to grow. It's now 43%. It's been a relatively stubborn number to change. The number of newborn deaths in sub-Saharan Africa has actually gone up in recent years, even while child and maternal deaths have fallen. Why is this? In some ways, the answer is pretty simple. We're not taking advantage of the promising interventions that we have available already. 35 years after the introduction of kangaroo mother care, we're still sputtering through the introduction phase of this incredible intervention. Amazingly, we lack still an indicator for even measuring how well it's being scaled up. And few countries, fortunately South Africa is really an outlier here, have embraced this intervention and are scaling it up as something for every preterm baby, and better yet, for every newborn. What's it going to take to achieve this? And what are we waiting for to scale this up? The use of antenatal corticosteroids is really no better. In low and middle income countries, the current coverage of this intervention is about 10% at best. This medication is already on WHO's essential medicine list for other indications. And what's most frustrating is that in many cases, implementing this intervention is nothing more than moving it from a consultation room to the maternity ward in the same health facility where it's already being used. What's it going to take to achieve this? And what are we waiting for to scale up this intervention? With the evidence in hand that we have for reducing newborn deaths and with the action around Millennium Development Goals, focusing in on the unfinished agenda for mothers and for children, we have what we need to generate the necessary attention, the resources, and the programming to address this issue. And what are we waiting for? I remember well an incident a couple of years ago when I was visiting Uttar Pradesh in India, and I was visiting a project that the Gates Foundation was funding to promote improved newborn care in communities. And we were met at a door by a woman named Meena. She was holding her newborn, and she had a 2-year-old at her feet. And we were asking her, what had she learned through this program that had helped her, and how had it affected her life? And we were having a great conversation. She was talking about how she had learned about the importance of delivering in a health facility, which she had done for her last child, unlike her previous 3. She talked about the importance of breastfeeding, about avoiding feeding other substances. She talked about keeping the baby warm, all things that she said had really helped her in caring for her newborn. And then we asked her a question. We said, do you want to have more children? And the conversation took a dramatic turn. She kind of looked down, she paused, and she said, no, actually I don't, and I don't even know how I'm going to take care of the children I have. I don't know how I'm going to feed this newborn baby when it's time to move on to feeding the baby other than breast milk. I have no hope for educating these children. And then she pleaded with us to take her 2 children with us back to the United States. It was heartbreaking, pleading for us to take the children to a place where they could be fed and get an education. This was a jolting wake-up call for me. The project we came to visit was highly successful at implementing newborn care practices. But we had done nothing about family planning, and she and her family were now in a desperate situation. If only we'd been more thoughtful in understanding and addressing her and her family's critical set of needs in a more holistic way. This is a great reminder of the importance of linked maternal and newborn care. We've been talking a lot about that this morning. And family planning has got to be part of our conversation, one of the most cost-effective things that we can do to save the lives of mothers, newborns, prevent stillbirths, and abortions. We also can't have this conversation without talking about nutrition and the intrinsic links between adolescent girl nutrition, nutrition for mothers, and its links to newborn health. And what this experience that I had in Uttar Pradesh really made real for me is that within any complex holistic system, there are certain leverage points where we can intervene to have catalytic impact. Those leverage points can be both within and outside the health system. And if we focus narrowly on the newborn community and on the newborn health agenda, we may miss many critical opportunities for catalyzing impact. One example of changing these levers for newborn health comes from Nepal. During the past decade, the government was the first low-income country that came out and set a national newborn health strategy. They went on over a 10-year period to reduce neonatal mortality by 30%. Health improvements for newborns in Nepal can be attributed to a number of system changes for newborns, but directly focused on newborns in only a few instances. The country reduced its total fertility rate through improvements in family planning. They made improvements in female education. More women received skilled care during childbirth. Frontline workers were empowered to provide child health interventions such as vaccination and pneumonia case management, and this provided a platform to build upon that also benefited newborns. So I go back to my list of questions and I'll add a few more. How do we take successes like Nepal to a global level? What will it take to scale up the interventions that we know work and see the incredible promise that they bring? How do we take Nigeria's state initiative of introducing a locally branded form of chlorhexidine to national level? How do we influence things within and outside the health system that are important for newborn survival? Well, I don't have the answers to these questions. I hope that we'll ponder them over the next 4 days. But I would argue that what we need is a change in the status quo, a change in the way we partner together for newborn health. This field started with a few passionate champions. It's grown to all of us here in this room. All of us are champions for newborn health. And it's time now to expand the group and expand our partnerships beyond our domain of familiarity and influence. It's time to change business as usual. And that change depends on all of us. There's a great example from a community in southern Honduras where they set a new health strategy, and as part of that, women developed birth preparedness plans. But what was really interesting about this is that they combined a focus on quality of care with measures to ensure that women got prenatal care. This town made it a law that husbands were required to take their wives to the clinic for care. And what if they didn't do it? Publicly, they got to sweep the streets. Sounds pretty unorthodox, doesn't it? It's pretty out there. But this change got buy-in across the entire community. It changed the way the community looked at prenatal care forever. It's now a family responsibility. It's something that the community provides oversight to. And this leverage point existed outside the domain of newborn care and really outside the health system, but it was tremendously powerful. As these examples show, within this complex system of newborn health that we all work in, there are levers that exist that we can pull that are not directly linked to a newborn baby. Saving newborn lives is a vital piece of the entire global development agenda, contributing to the long-term economic prospects for poor countries. The newborn is the nexus to everything else along the life cycle. And this is the engagement model that we need to change. We need to look beyond those 28 days. We need to look at the entire system. In a new construct of broad strategic and catalytic partnerships, we need political will driven by clear, ambitious, yet achievable goals. And we need measures to mark progress along the way and ways to improve our implementation as we go, responding to what we learn. We now have information that can help us to do that. We have information on neonatal mortality as the ultimate indicator. But we also can start measuring more smart indicators along the way. Antenatal care, skilled care at birth, the number of women treated for malaria during pregnancy. We have information on these things. But we have less information on a number of really critical pieces that we need. How many babies are held skin to skin? How many mothers with threatened preterm birth actually get corticosteroids? How are cultural practices influencing care? And we have little information on the quality of care at all levels, and this is a critical piece of information that we'll need in order to scale up effectively. So with this conference and with the energy here, with all of you here in the room, we have the opportunity to build on the extraordinary progress that we've seen thus far in women and children's health. And just as in child health in the earlier days, so much of what we can do is really very simple. We're all aware of the challenge of creating a more coordinated approach to reducing neonatal mortality and incorporating neonatal health into other elements of programming. But this is our chance to create the political will necessary to engage partners all along the continuum, and even beyond our domain of influence, looking at all possible levers to influence newborn health. We've already done a huge amount to improve newborn survival. Now it's time to broaden our partnership model and look beyond 28 days. Yes, there are many things within our community that we can do to improve newborn care, and we need to continue doing those things. But what are we missing if we don't think creatively to forge partnerships outside of our circle? We need to expand our partner base and ensure that all groups focused on women and children's health elevate newborn care within their programming. Well, I've asked a lot of questions. These are difficult questions, and I hope we'll think about them over the next 4 days, and I'm convinced that we can answer them. I'm convinced that we can accelerate our progress. Now is the time to make a global commitment to newborn survival, actually a global commitment that's grounded in collaboration, partnership, and holistic action. This conference and the Global Newborn Action Plan are a great place to start. So what are we waiting for?